The second day at the COMy Congress was really an exciting one. Obviously, it can take hours to go through everything that was discussed. This is why I thought to focus on the keyword of day 2 of COMy, namely MRD, measurable or minimal residual disease. So during the day, we had several talks, several sessions looking into the impact of MRD from a prognostic point of view, but also from a dynamic point of view, I would say, how to guide a treatment. And obviously, this is really a very hot debate. I think what we can glean from the different communications is that the prognostic value of MRD is really well established, especially when it comes to sustained MRD. Obviously, there are still debates about the threshold, whether it should be kept at 10⁻⁵, as recommended by the AMW group, or should we move forward into a deeper threshold like 10⁻⁶. We had also questions and debates about the role of imaging, especially PET scan, in order to further, I would say, enhance the results of biological MRD. And obviously, as you would guess, most of the myeloma community members are more and more believers in the value of MRD. Now, the second part was about how can we use MRD to guide therapy, to drive therapy. And we had, for instance, a few sessions dedicated to the presentation of the ongoing protocol looking into this specific question. And we had a lot of discussions about the IFM MIDAS trial. We had discussions about the second Master 2 trial by Dr. Costa, and many other issues and debates. And the bottom line is to say, well, now patients are going to be randomized based on the MRD status to receive this or this therapy. The idea is that if you are able to achieve MRD negativity, maybe we can de-escalate, for instance, postponing auto transplant. On the other hand, if the patient is MRD positive, it may be a good option to, I would say, further escalate treatment, and why not double auto or introduce immune therapies. So as I mentioned, it takes hours to go into all of these details, but this is the global philosophy, I think, of the discussions. And last but not least, we had also a session looking more carefully into the value of MRD, I would say, in real-life practice. And actually, it proves clearly that there are a lot of colleagues who are already using MRD in their routine practice because, for instance, a patient developing some severe side effects after maintenance therapy, if you are able to show that this patient is in a sustained MRD negativity, then you are more comfortable, I would say. You feel less anxious discontinuing treatment in such patient. On the other hand, maybe a patient with an aggressive disease, high-risk cytogenetics, and remaining MRD positive, some physicians are considering upgrading, I would say, or switching gears when it comes to treatment. So clearly, this MRD story is going to dramatically modify the way we envision multiple myeloma treatment. And at the end of the day, all of this is about good news for the patient, because probably, and during the meeting, we'll hear also a lot about it during day 3, for instance, that it is something which is mandatory, I would say, to achieve cure in the majority of patients.